with us.
Hello, can you hear me?
Yes, yours.
Perfect. I hope you join this course till now. I have to say, if I was a patient myself, would prefer the hydrotherapy. So, I'm Maria Patramani. I'm a collaborator of third orthopedic department of Υγεία Hospital. And let's begin with our patient, our approach. The patient was suffering for a very long period of time, which affected her psychology a lot. I was present during her first visit when Mr. Antonogiannakis assessed her condition. My presence there helped me to understand her needs and everyday difficulties met. When she decided to undergo the revision surgery that Mr. Antonogiannakis suggested, she was immediately provided with the guidelines while highlighting what to expect and the step-by-step procedure she had to follow. Once the decision of proceeding with the surgery was taken, the first step was to complete a preoperative evaluation. In the pre-op evaluation, we record the range of motion, pain levels, and use questionnaires which assess everyday difficulties and patients' quality of life. Following the pre-op protocol, I discussed with the patient and explained all the steps and goals we want to achieve for the post-operative period. It is very important to reassure our patient and give them the confidence and the positivity. It is also important that our patients feel comfortable. They need to feel that both doctors and physios are approachable and that both of us will use the best possible means to achieve the best result. Hence, the importance of physiotherapists and doctors' collaboration and continuous and everyday contact that we should have with them in order to offer top results for our patient. Moreover, regular contact with the surgeons help us have in-depth knowledge of what happened during the operation, what they want us to be careful of, what we should expect, and where in particular to insist on during the rehabilitation program. The doctors are there for us, for anything troubling us, and together we can overcome any obstacles in our common effort to help the patient recover faster. Mr. Antonogiannakis in particular emphasized on helping the patient become functional and independent, as well as be pain-free and does not stick in just measuring range of motion and strength. Coming back to the patient example, the main purpose was to improve her daily living. It goes without saying that different patients' lifestyle demands different approaches. For example, if we're dealing with an elite athlete for another situation, the main focus would have been to help the athlete return as soon as possible to her athletic life. So, when I saw her the first post-op day, I supposed how to perform daily tasks in order to be independent. For example, how to eat, get dressed, brush her teeth. Also, I performed with her the first exercise that will help her reduce swelling and minimize the pain, like pendulum exercise for the scapula without including shoulder movement, and active exercise for the elbow, wrist, and the hand. Moreover, I directed her attention to not bring her shoulder in adduction combined with internal rotation and extension of the shoulder in order to avoid dislocation. In this patient, doctors delayed rehabilitation process as it was a revision surgery. However, she was guided to use her arm as much as she could with minimal pain in front of her body. And this is the magnificent of reverse. I'm sorry. In front of your body. And this is the magnificence of reverse. The patient has freedom of movement real soon. Can you hear me? As far as the rehabilitation program is concerned, in our clinic, we usually see the patient once a week. We demonstrate an exercise program according to individuals' capabilities, and we perform the exercise together in order for the patient to be introduced to the philosophy of the rehab process. We suggest to repeat the exercise once a day, and after a week, we evaluate the situation and we give a new program based on the progress made. This is a way for the patient to understand that the protagonist in the rehabilitation process is themselves and that physio's role is mainly supporting and to coach them. I followed this strategy with her, but due to residence on an island, the frequency of our session was once per 2 weeks. The first session I had with her was 3 weeks from the surgery. She was calm and relieved because she had no pain, and she mentioned that after the surgery, she slept overnight after many months due to night pain she had been experiencing pre-op. The plan was to reach a range of motion which is functional and pain-free, and to strengthen the deltoid and the scapular muscles by gradually increasing the level of difficulty. But how we did it? By changing position and play with gravity, with a rhythm. The rhythm must be slow in order to retrain the muscles, to reach the range of motion till the patient feels only tension, and with a number of repetitions. I started with exercise that strengthened the scapula because this specific arthroplasty, scapula takes more loads. At the beginning, the exercises suggested didn't need the shoulder participation, but after a few days, the shoulder was involved too. At the same time, I gave her a assisted exercise that began with closed chain and continued with open chain assisted exercises. In every exercise, I instructed her to keep the final position for about 5 seconds in order to have a bit of stretch without suffering. This helped her to gain range without pressure. The main problem in this patient, especially in flexion and in abduction, between 60 and 120 degrees due to months-long muscle immobility. I started to work with internal rotation and horizontal adduction after 6 weeks. Moreover, I insist on strengthening and stretching the biceps because of the old rupture she had, causing her continuous pain due to muscle construction of the long head of biceps. Excuse me. We must be really careful with the deltoid. A sudden increase of the deltoid activity during rehabilitation could lead to excessive acromion stress. During the rehab period, the patient suffered from pain in the deltoid muscle as well as in the biceps. These were handled by medication and by an easier exercise program or even complete rest for some days. As we know, reverse has a limitation in the range of motion. The main goal is the patient to have a functional range. In my experience, I have seen that patients with reverse at the end of rehabilitation have no significant limitation to prevent them from everyday activities. They can also have a light athletic activity. After 3 months, her range of motion was 120 in flexion, 100 in abduction, 30 degrees in position 1 in external rotation, 50 degrees in position 2 in external rotation, and the internal rotation was in sacroiliac joint with pain in final position. There were certain levels of difficulty, as for example, to hold an object above the shoulder. After 6 months, the patient had 150 flexion, as you can see in the video, 110 abduction, 30 degrees in position 1 in external rotation, 60 in position 2 for external rotation, and the internal rotation was in sacroiliac joint. She had more convenience of movement, but still she had ups and downs. After 1 year, the patient had 160 flexion, 150 abduction, 40 degrees in external rotation in position 1, in position 2, 60, and then the internal rotation was still in sacroiliac joint. She was experiencing no pain and was capable of using her shoulder in everyday activities without ups and downs. As you can see, we have a restriction in internal rotation, but it's a functional range. The purpose of internal rotation is for the patient to have the ability to reach the genital area. Thank you so much for your attention.